But thank you so much for everyone for signing on and joining us. I'm so excited. I'm very excited to present the monoclonal antibodies use in post-acute long-term care settings, presented by members of CMDA and also mAb Colorado with the University of Colorado and the CDPHE. Let me go ahead and share my screen so you can see our title slide here. Okay, I hope that's working. And so we're so pleased that you're all here with us today. And I'm going to go ahead and let everyone who's presenting and on the panel go ahead and introduce yourselves. If you don't mind just going in the order of the slide, tell us who you are, what you do.
So I'm Diana Tapay. I am a pediatrician on the medical guidance unit with the COVID response team at CDPHE.
I'm Hillary Lum. I'm a geriatrician and palliative medicine physician at the University of Colorado and the Rocky Mountain Regional VA Medical.
I'm Allison Villegas. I'm a physician assistant, and I work locally in nursing homes here with Optum, and I'm on the CMDA board.
Good afternoon. Thank you again for taking the time to join us. I am Jen Conley. I'm the Division Director of Pharmacy for the Veterans Community Living Centers. I'm a long-term care pharmacist.
Hi, everyone. I am Dr. Clay Watson. I am the Medical Director for Optum in Colorado and Utah, and I am also an infectious disease doctor.
Great, and Leslie?
Thank you. I'm Dr. Leslie Eber. I'm a medical director and geriatrician here in town. Thank you for having me.
And I'm seeing Palat. I'm helping to moderate with Leslie. I'm a geriatrician, nursing home medical director. I work with LTC Rehab, and I am the president of CMDA. So thank you all for being here with us, and special thank you to our presenters. Today, we're going to talk about the use of the COVID-19 monoclonal antibodies in post-acute long-term care settings, who is eligible, how do you order it, and other questions that people might have. And I believe we'll have plenty of time at the end for questions and answers, but feel free to put your questions in the chat box as you think of them. And we can, in the chat box, we can address them, and we can either address them as we go, or if it needs to be saved for the panel at the end, we're happy to do that. So we'll go ahead and start with our first slide and our first speaker, and that's Diana Tapay. Go ahead.
All right, so I am just going to start with kind of an overview of where we are with COVID in Colorado and the monoclonal antibodies that are available. So this is the graph of COVID cases in Colorado by the date that they were reported to the state, and it's a 7-day average to kind of smooth the graph out a little bit. But you can see our biggest peak was like November, December of 2020. That was last winter. And then we had another little bump in April to May as people started getting vaccinated and restrictions started to be lifted. And now we are on the upswing again now in August and September with rising numbers of cases again, which is why monoclonal antibodies are important as the only outpatient treatment that we have for COVID at this point. Next slide, please. So this is just something that shows you, this graph shows you the percentage of each variant in the cases that were sequenced in Colorado, broken down by week. Again, these are the cases that were actually sequenced. So it's not, we don't sequence every single swab that gets run in Colorado. But you can see that the Delta variant in that pinky purple color started to appear in May, and it quickly took over and is now not quite 100%, but more than 99% of our sequenced variants in Colorado. Next slide, please. So the current monoclonal antibodies that are available for outpatient use. There is Casirivimab, that is the one that's known as Regenco V. That one is available for both treatment and post-exposure prophylaxis, and it comes in both IV and subcutaneous formulations. Sutrobimab is available only for treatment and only in IV form, and Bamlanivimab is available for treatment in the IV form. The Casirivimab and Bamlanivimab are the two that are distributed by the federal government, so there's no charge to obtain those. So Sutrobimab can still be ordered and obtained, it just doesn't come through the federal government, which means you do have to pay for it. And then next slide, please. So this is just a timeline to go over quickly the bamlanivimab etesevimab timeline, because it's pretty much been a roller coaster from the word go. So bamlanivimab was first authorized November 9 of 2020. In February 9 of 2021, they authorized the bamlanivimab etesevimab combo. Etesevimab has never been authorized as a monotherapy. It's only distributed in its own singular vials so that it can be paired with bamlanivimab that had already been distributed. April 16th of 2021, they revoked the authorization for bamlanivimab alone. The combo was still fine, but bamlanivimab alone, there was too much resistance in circulating variants, so they revoked its EUA. June 25th of 2021, so just now 3 months ago, they paused distribution of bamlanivimab and etesevimab. They did not revoke the EUA for it. They just paused its distribution due to increasing circulation of resistant variants, primarily the beta and the gamma variants. And then just a couple weeks ago, on August 27th, 2021, they resumed distribution of bamlanivimab and etesevimab for any area where the resistant variants, there are 5 of them listed there, make up less than 5% of the circulating variants. So it's important to understand that right now, the entire country qualifies to be able to use bamlanivimab etesevimab, but that restriction is still in the amended EUA. Next slide, please. So just a couple resources to keep in mind that you will be able to go find and reference later. They get updated all the time, I know, because I'm the one doing the updating. One is the Residential Care Facility Comprehensive Mitigation Guidance Document. Under the respiratory illness or a positive test is identified section, there is a section that we recently added on monoclonal antibody therapy. I have a screenshot of part of it there. The whole thing actually goes on to more than a page, so not the whole thing isn't there, but that's where we mostly just have the reminder that anytime someone in a residential care facility tests positive, the supervising provider should be notified so that they can assess whether they qualify for monoclonal antibody therapy. Next slide, please. And then living on the CDPHE website, we do have a page called COVID-19 treatments. And it reviews monoclonal antibodies, what they are, who qualifies, and at the bottom of the page, there is an FAQ for both people saying, how do I get these, you know, which mostly tells you to talk to your provider, but also for the instructions for how sites can order them and provide them, and how providers can either become a site that provides them or refer their patients to a site. And that's what I have for the intro.
Thanks so much for inviting me. I'm going to sort of speak on behalf of our Monoclonal Antibody Colorado project team, which is funded by the NIH and based at the University of Colorado, with a key aim of increasing awareness and dissemination of materials to help community members and providers be able to have more awareness. And so this will be about the context in Colorado to hopefully be helpful to you as long-term care providers if your facility is not able to administer monoclonal antibodies and instead you're looking for a community-based option. So next slide, please. We wanted to provide a little bit of data related to the surveys that providers filled out. CMDA members received the survey, so you may have completed it, and I apologize for my echo. So in terms of provider survey results, we have heard from more than 300 providers across Colorado, and several of the barriers to referral are noted here. Collectively, this helps us to think about how we can simplify the ordering process and also provide clear information about availability, treatment, cost, and how we really want to emphasize early testing because the data supports early administration of the monoclonal antibodies. Next slide. So this is an overview of showing us a picture of what Dr. Tapay has described, that we really want to target the antibody therapies. They are the only effective approved antiviral treatment for early outpatient mild symptoms. And the idea is that we're able to administer at a time before viral load is overwhelmed, and we're actually able to see responsiveness in decreased viral load after giving the therapies. Next slide. This is a preprint that was released June 6th about the Regenco V antibody cocktail. This was a very large study of 4,000 patients and emphasizes that this and other cocktails have demonstrated reduced risk of hospitalization or all-cause death. So in panel B, placebo is in gray, the treatment group is in blue, and you can see that there was reduced proportion of patients with hospitalization or all-cause death. And then in panel C, also important to see the resolution of symptoms. So in this study, symptoms resolved 4 days faster in the treatment group compared to placebo. The rates of serious adverse events were also more frequent in the placebo group compared to those in the 2 doses that they tested of Regenco V. And infusion-related reactions within that first 1 hour were very rare. And in fact, this study did not have any anaphylaxis. Next slide. So as mentioned, subcutaneous is now available. And this slide just briefly gives an overview that when either IV or sub-Q are administered over time, there is an equivalent reduction in viral load among those positive for SARS-CoV-2 and then administered this treatment. And there are these curves at different doses. This was provided by Regeneron to our study team for sharing publicly, but has not been published. Next slide. So I just wanted to sort of frame us again that we are recommending that we consider monoclonal antibodies for individuals who test positive. Next slide. And the recommendation includes both treatment, as was noted in the residential care facility guidance, and then also nationally, the FDA has expanded the authorization for Regenco V to be used as post-exposure prophylaxis. And we'll be saying more about this throughout our discussion today, but I wanted to show some of the data for which this recommendation was put into place. And we'll discuss the nuances of which patients you might consider post-exposure prophylaxis for. Also, I wanted to highlight that in August 17th, this is such a rapidly evolving situation. In August 17th, the NIH guidance did direct us to prioritize use of monoclonal antibody treatment among those who have tested positive over individuals for post-exposure prophylaxis if you're in a situation where there are logistical challenges to treating everyone who is eligible for either treatment or post-exposure prophylaxis. Next slide. And this is that summary of that statement. So if you wanted to go to the NIH guideline, you can see how we would use the post-exposure prophylaxis, especially if there are logistical complaints. We'll share all of these slides so that you have the links. And it is a rapidly evolving situation, as with all things COVID. Next slide. So I want to just provide a summary of the efficacy data so far that we think is helpful for shared decision making. Multiple studies have now shown that antibody cocktails can reduce the risk of hospitalizations or death by 70%. Monoclonal antibodies at the person level help decrease symptoms by 4 days on average. And in fact, anecdotally, we've noted individuals feeling better within 24 hours, just a significant relief of the symptoms that were otherwise escalating. The antibodies are effective against Delta variant. They are available by sub-Q, as we've noted. They can importantly be given regardless of vaccination status, and in some ways might be prioritized when you have suspicion that someone might not be fully mounting an immune response related to their vaccine. That might influence your decision making to prioritize use of post-exposure prophylaxis, as noted here. Next slide. So in terms of general tools that we have introduced broadly, and then my colleagues are going to introduce more specifics within the residential care facility perspective, we think that this checklist is a helpful overview in our heads and even tangibly if you're looking for resources. So determining eligibility, discussing treatment with patients or their appropriate family members or decision makers, identifying the treatment location, especially if that's outside of your facility, referring and ordering, and then acknowledging and addressing cost, transportation, or access issues. The handouts that I'm showing you are downloadable from our mAbs Colorado website, and we're happy to customize if that would be helpful for your use. Next slide. So just wanted to highlight some of the resources in terms of finding infusion sites in Colorado. The CDPHE website is the same resource that Dr. Tapay highlighted, and I think this is our first go-to for up-to-date maps, as well as other information about where monoclonal antibody treatments are available. You can also go to the Combat COVID HHS Protect Public Data Hub, which will show you all sites that have ever ordered from the centralized distributor to find out if there is a location that might not be on CDPHE's site. The map on CDPHE's website includes those sites that have registered with CDPHE. So in some cases, that doesn't include home health agencies or long-term care facilities or pharmacies that may not have gone through the process of registering, in part because those long-term care facilities may be only specifically able to serve and provide mAbs to their residents. Next slide. And this is a slide screenshot of what the COVID-19 monoclonal antibody connector tool looks like on CDPHE's website, and especially if you are ordering sort of as an independent provider seeking to have treatment administered at a affiliated or close proximity healthcare facility. This is the way that you would identify that location and send a referral and order through this secure REDCap form, which then goes to the infusion sites. Those infusion sites then follow up and directly contact the patient or their care partner based on the information, contact information that you enter into the secure form. Next slide. And just a final word on cost and access issues. We have a lot of concern and just attention to wanting mAbs to be as equitably available as possible. We are glad that they are available through the federal government for the medication. We know that facilities then are able and appropriately charging facility fees, though that can make it difficult at the consumer level to know exactly what charge might come to a person, especially if they are uninsured or underinsured. There are no out-of-pocket costs for Medicare patients. That's clear on CMS's website. And so in this context, where access can be difficult, we have noted that the use of subcutaneous, even at the clinic level or potentially in facilities, including maybe assisted living facilities, depending on their resources and if they're doing on-site testing, subcutaneous injection may be a feasible way when IV is not feasible. And then home health injections are also happening. We know a few companies that are coordinating with health systems and doing that. Next slide. So there's a resource page included in the slide deck, and for any facilities interested in setting up, I really want to point out the HHS playbook. That has been recently updated at the end of July, and in combination with the CDPHE website, as well as other resources that we're talking about today, I think the HHS playbook is quite comprehensive and pretty user-friendly. And next slide. Thanks so much for your time.
All right, so our next section is going to be, really drilling down all this great information into how it applies to us specifically in long-term care facilities. So we kind of have it down into 4 easy steps, but we'll start out with a case from Dr. Singh Palat.
Thank you. I agree. It is great information. I'm just going to stop sharing for a moment so I can tell you about my patient, Mr. D, and what I went through in terms of the decision-making process for his monoclonal antibody treatment. This is a patient, Mr. D, that I saw about a month ago, and his roommate actually was diagnosed with COVID-19. The roommate had all the classic symptoms, fever, shortness of breath, cough, and he had hypoxemia. So his roommate was sick enough not to be eligible for treatment with monoclonal antibody. The 2 gentlemen were separated immediately, and Mr. D then came to my attention for possible post-exposure prophylaxis using monoclonal antibody. And I went through the websites that Dr. Tapay and Dr. Hill had, Dr. Lum just showed us. And I thought, well, for post-exposure prophylaxis, it seems like he is the kind of person who is at high risk for getting complications because he's older and he has comorbidities. It seems like with his low functional status and living in a nursing home, he seems to me like someone who may not mount a robust immune response to COVID-19 vaccination, even though he's had the vaccination. And then certainly he's been exposed because he was in the same room as a person with COVID. That was my thinking. And this was very early on. It was my first person who I'd considered the treatment for. And I was very lucky that this man lives in a nursing home where the pharmacy and the lead pharmacist, Jen Connolly, had already thought ahead and prepared supply of monoclonal antibody and also set up protocols to make it easy for me to order it. And so as I was going through this process for the very first time, the facility, of course, had its surveillance testing for COVID-19, and Mr. D's test came back positive. So all of a sudden, he was a person with COVID-19 that I was looking at for possible treatment with monoclonal antibody. Now, if he had no symptoms at that time, the FDA might consider him as being a positive case that's asymptomatic and actually not eligible for monoclonal antibody. And of course, I talked to him, did some further questioning, and he did acknowledge he had a severe amount of fatigue, and it seemed to be related to his COVID-19 diagnosis. So I said, okay, I think you have a mild case of COVID-19. Let's go ahead and give you the treatment. The facility actually had a full-blown outbreak. We ended up getting prophylaxis for many people in that same unit in that nursing facility. And unfortunately, Mr. D's roommate died from COVID-19 shortly thereafter. And when I talked to my patient, he was grateful that he had had a chance to be treated. He was grateful that we'd given him some hope and something to address his chances of getting a severe case of COVID-19. And ultimately, it ended up very good situation. So I'm curious to see through Allison's presentation just how she would think about this and decide to give someone monoclonal antibody.
Thanks, Singh, for sharing that story. And I think it highlights a lot of great points. Obviously, the first step is to determine if your patient is eligible. This slide actually came from Diana and the folks with the monoclonal or mAbColorado.org. It's a great flow chart that helps you kind of figure out whether or not the patient is eligible. Obviously, they must be positive and symptomatic, but mild and moderate so that they're not hospitalized. No increased or new oxygen demands. The treatment needs to be within 10 days of symptom onset. And they must obviously, this won't apply to our patients, but be over 12 and at least 88 pounds. And then be at risk for complications for severe COVID. So you can find this flow chart on mAbColorado.org. Next slide. Looking at patients who have the high risk criteria, if you, and I won't read all of these on the slide, you guys can read it, but if you look at these, I don't know how many of you were able to sit through or attend ECHO's monoclonal antibody, but Dr. Fish presented, and I really liked the way that she reframed the question is, not why does my patient qualify or why are they eligible, but why wouldn't they be? I mean, our patients are complex, have a lot of chronic comorbidities. So really it is a question, why can't your patient qualify for this treatment? And if you can't come up with an answer, it's likely that they do. Next slide. And then we did talk a little bit briefly about the post-exposure prophylaxis eligibility. So the requirement for that is that they have high risk for developing severe illness, and they're either not fully vaccinated or they're expected to not adequately respond to the vaccine or mount a robust immune response. And they have to have been exposed to an individual infected with or be at high risk of exposure, which in a nursing home, and that will be an interesting question for the panel later is, what constitutes as exposure is clearly in Mr. D's case, being exposed to his roommate is clearly an exposure, but we can talk a little bit about what that might look like later. Next question or next slide. And then you're going to want to have, the shared decision-making and informed consent with the patient or their power of attorney. The first thing I would start with is the need for use. This is where I'd really highlight with the patient where they qualify. What are we concerned about them specifically? Why do we want to treat them? I'd want to go over with them the evidence for use. I might pull some of Hillary's information from the studies, especially looking at, am I treating them for a known positive, or are we doing a prophylaxis treatment, and kind of talking to them, of course, in layman's terms, that they might be able to understand what benefit there is for us using this, which of course the benefits of the medication, as Hillary had on her slide, can reduce hospitalization and death by 70 to 80%, reduce the length of symptoms by 4 days. Symptoms can start to improve 1 to 2 days after treatment. If you're using it prophylactically, it reduces your chances of getting COVID by 2 to 5-fold. So a lot of excellent benefits. Of course, patients are going to have questions and their loved ones about risks. They may be concerned that this is under an EUA still. Is this, quote unquote, experimental? Discuss with them that monoclonal antibodies have been in use for decades at this point, and this isn't experimental medicine. It's just, under emergency use. And we could talk about, obviously, the risk of the infusion itself. Headaches, dizziness, nausea are pretty common side effects. The big thing everyone worries about is anaphylaxis, and we can talk about the rarity of that, 1 in 1,000. How would we be prepared for that as we do the infusion here in the nursing home with our e-kit and our vital monitoring? And we'll talk about that in a later slide. And once we have all this, conversation with the patients and their loved ones, you're going to want to document this. There's no form that needs signed, but with any, big treatment decision, especially something that's under emergency use, you're going to want to document all of these things that you just reviewed with them, why your patient qualifies, where in the EUA do they fit, and then that you discuss the risks and the benefits. And I would be specific there and just document that everybody is on board with the plan of action. And if you consulted anybody, your good old pharmacist or your attending or your medical director, make sure you document that as well. Next slide. These are great graphics also that I stole from Diana and the mabcolorado.org. I would take this opportunity when you're talking to the families and the patients, really take the time to educate them, make sure you answer all of their questions, because this is a great time for us as providers to dispel some misinformation and myths that are going around about this treatment. And so I would really encourage you guys to take the time to, give them these graphics, send them to these websites. A lot of this information is, really accessible to the general population and would help them understand, and hopefully we can get some good information out there. Next slide. And then we have some cases from Dr. Eber.
Thank you so much, Allison. So I have 2 cases that I wanted to share with everyone that happened here in Colorado and the lessons I learned through them. So my first case happened in June of 2021. We had an unvaccinated dialysis patient who became COVID positive. And by then I thought, oh, I know a lot about monoclonal antibodies. I'm all set. It's going to be so easy. And we're going to talk with the patient and her family, and it's going to go so smoothly. But it was still challenging. So the patient was very interested in monoclonal antibodies. At first, she didn't have any symptoms, but then as 24 hours went by, she started to have some symptoms. when I worked with our long-term care pharmacy, they actually were struggling to get monoclonal antibodies. And that's something I didn't really realize could happen. Many of our panelists actually helped me connect with a infusion center, and they had to go through a process to be approved by the infusion center. And that was a learning process as well, because we wanted to move quickly. We knew time was of the essence. And then we couldn't get transportation. We had a positive COVID patient, and that was a challenge as well. Our patient did start to get more symptomatic, but she still had mild symptoms, no increase in oxygenation needs, no need for hospitalization. She did get to the infusion center. She got her monoclonal antibodies. And just as Hillary alluded to, she was actually feeling better within 24 hours. She didn't have to go to the hospital after that, and she resolved. So that was a really good outcome. But I had some take-home messages for myself that I would like to share with you as well. Even though I knew a lot about monoclonal antibodies and I was on board within the first few hours, it still needed more planning than I realized. I really wish I had called my long-term care pharmacy and we kind of had more communication about what to do in preparation if we were to need monoclonal antibodies. And so that was my first lesson learned. My second patient was just a few weeks ago, and it was an unusual case. She was having a PCR for COVID-19 as a pre-op exam, and she turned out to be positive, but it actually took a few days for us to get that result. She is very alert, oriented, and active in our community. And so when she was positive, she was able to give us a list of all of the people she ate all of her meals with, obviously unmasked. They all were vaccinated, but this was a significant prolonged exposure 3 times a day with meals and activities. And so the next thing I did that I knew that these were significant exposures was to personally talk to each one of the providers who took care of these patients and made sure that they knew about this exposure and that they were comfortable talking to each one of these patients about prophylaxis, monoclonal antibody use. They were. We shared the information sheets and what should be shared with the patients and families. We asked the providers then to communicate back to us if the resident would like to have monoclonal antibodies. And then I coordinated with my long-term care facility. They had the monoclonal antibodies. We decided we wanted to do sub-Q. So then I had some additional questions. Does it come in an IV bag? Are you going to deliver a vial? What's the scoop? And so they said it came in a 10 milliliter vial. That was really helpful. I had already heard that I needed 4 syringes and they each were to have 2.5 milliliters in each syringe. And I should give the shots in 4 different places. And so that was helpful. I had to kind of work that through. And then I had to talk with my DON and our nursing staff to make sure that they were comfortable. Did they know what to expect about, monitoring the patients afterwards for 1 hour? Did we have our e-kit ready to go? And so all of that took time and energy, but it worked out really successfully. We gave 8 people prophylactic monoclonal antibodies. So, and we had no side effects. It was really well tolerated. So then my take home message for that experience is that it still takes time. It still takes preparation and ensuring that all of the providers were on board. That was a little bit more surprising. I didn't realize that I would need to do that step, but it was really helpful. So thank you. And I'll turn it back to Allison.
Thanks, Leslie. Yeah, I mean, those are great learning points through there. And I think too, I'm not sure, did you mention the time frame between the 2 cases? I think one was earlier on in the...
Yes. One was in June. And so that's when we were kind of more brand new with monoclonal antibodies. And the other one was in August, where everybody felt more comfortable.
But I still wonder, even if today, if you tried to transport a COVID positive patient, the challenges are still there for that. So then, of course, the next step in our presentation is to actually place the order. And this is where I'm going to bring in Jen Connolly to help me with these slides. As previously noted, there are 3 that are available and they're all mouthful, so I will be giving the short versions of them. But BAM-EDI, the order is 700 and 1400 milligrams. I actually pulled up my point-click care to see how the order goes in. And when I was working through these slides with Jen, she pointed out that it's going to be different for each pharmacy, depending on how they supply it. So the best advice is, just write what the doses is. This would be an infusion by IV times 1, run it at 310 milliliters per hour. And the time that it'll run is going to be different depending on how they send it to you to reconstitute. And this can be run by pump or gravity. Jen, do you have anything you wanted to weigh in on BAM-EDI?
Yes, so pharmacists probably won't be sending it to facilities to reconstitute. I don't know for sure, but that's not how I set it up, or I think that it's been set up. We reconstitute it for the facilities at the pharmacy, so it'll depend on how big our 0.9% sodium chloride pre-filled IV bag is to that infusion rate. But the manufacturer supplies the BAM-LAM and the EDI to us in 700 milligrams per 20 ml vials. And those are individually supplied, BAM-LAM and EDI separately. So it takes 1 BAM-LAM vial of the 20 mLs and 2 EDI 700 milligram vials of 40, so that equals 40 mLs. And then we reconstitute it into the sodium chloride 0.9% pre-filled bag. And then that's when we send it out to the facilities. There's a little bit of a time frame because it has no preservatives in it. So we want to make sure that we hit the go button and we're sending it and we're being timely. And there's a constant stream of communication between pharmacy and facility. It's then infused at the rate of 310 ml per hour. And that is the same regardless of how big the bag is. And so the patients, the only difference is that patients that weigh less than 50 kilograms, we want to extend that infusion time out by 70 minutes. So those patients will be needed monitoring for a little bit longer. I don't think that we have a whole lot that qualify at that less than 50 kilograms weight. The other recommendation is also that we use a 0.2 or 0.22 micron filter with that infusion set. And that should all be supplied either in-house or from your pharmacy. You can work with your pharmacies and your supply managers to make sure you have all that on hand.
Great, thank you. Next slide. The next one is Sutrobimab, and this one is also just by IV, and it's 1 dose, 500 milligrams. This one, again, by pump or gravity. This is, as noted earlier, not available through federal funding, and so may not be as accessible through our long-term care pharmacies. Jen, do you have anything you want to add on that?
Sure. So we won't add a whole lot because we're currently focusing on the ones that are available through the federal funding, especially where I'm at. And I think there's no efficacious difference between Sutrobimab and the BAM-LAM, or not, I'm sorry, not the BAM-LAM, but the Regenco. So we are primarily using the Regenco, which we'll talk about next. But Sutrobimab is supplied as 500 milligrams in an 8 ml vial, reconstituted the same in the pharmacy and sent out. And again, this is so same protocol, 310 ml per hour infusion rate.
Great, next slide. And last but not least is the Regenco V. This one, we'll probably spend the most time talking about it because there is as mentioned, 2 different ways to give it. This can be given IV or subcutaneously. And this is, I've highlighted it on all the slides, but I think this is the one that's most important to make sure, well, they're all important, to discuss the treatment plan and the order with your nursing staff and leadership team in the facility. I wouldn't just blindly order these. Obviously, if you have COVID in your building, your DON and administrator are going to be heavily involved, but I would make sure that you're talking to the nurses on the floor and really outlining to them, what exactly it is that you've ordered, how you need them to administer it, what supplies they might need. And make sure that everybody is comfortable moving forward with it so that we're not just putting an order in and walking away. But this one in particular, because it is a little bit, because of the 2 different ways it can be given, it can be a little bit more confusing. So I'll let Jen take it away.
Yes, and also confusing because it's supplied so many different ways from the manufacturer. It's supplied as a combination product, and then it's also supplied as each individual ingredient. And so you have to really kind of pay attention, and they come in different vial sizes. But the important part to remember is that for the treatment dose, it is 600, 600, and that's going to be the same despite how big the supply is when it comes. So even with the syringes, when we divide it into the 4 syringes of the 2.5 mLs, that is the same dosage, even when it's supplied in different vial sizes or different constitutions. So it comes as either the combined 10 ml, so that's an easy 2.5 mLs into the 4 syringes, or it comes in individual vials that are already 2.5 mLs each, and then you would draw out 4 syringes, 2 of the Sutrobimab and 2 of the imdevimab, and then so it's still 4 syringefuls of the 2.5 mLs. This one is the one that we have supplied mostly to our facilities and our patients, and this is the one that Singh and I used in her patients when we treated them prophylactically. So this is the one we're most familiar with. The other thing that I like about this one is that it can be redosed if there's additional exposures after 4 weeks. And then for the re-exposures, we would dose it at half dose, and that's the 300 milligrams for 300 milligrams. But your pharmacies can work with you to make sure that when you receive your supply, you understand what it is that you have and how to administer them.
Great, thank you. And then the one other thing that I just want to note with this slide with this is, I know there always has to be an RN on site at the nursing homes, but the nice thing about the sub-Q is it doesn't require an RN. So if they are short-staffed, which I know a lot of our homes are struggling with staffing shortages, the sub-Q doesn't require an RN to administer. And so kind of considering staffing and time of day, that might help also kind of lend you into whether or not you want to do it subcutaneous or IV. I'm sure if the patients were to decide solely, we'd be doing a lot of sub-Q.
Absolutely. I think they have with the patients that I've talked to, they've been a lot more willing to do the sub-Q than the IV infusion. And then like you're saying, the timing. So not only do you have nursing timing for that hour monitoring after, but with the infusion, you have up to an hour monitoring during the infusion, where the 4 separate sub-Q injections really shortens that down by that first hour, that infusion time.
Yeah. And we saw from Hillary's slides too, I mean, the viral load reduction is pretty similar between the sub-Q and the IV. And so just things to ponder as you're ordering these. And then I think our last slide. Great. This needs to be out of the refrigerator at room temperature for 20 minutes prior to administration. It can be out for up to 4 hours. And then make sure you administer it as directed. I know the previous slides, which we will be sending out, just kind of talk about the different ways, IV or subcutaneous, pump or gravity. And then monitoring the patient is really important. Make sure you're monitoring during the time that the medication is being infused, and then also monitor for an hour afterwards. Having an e-kit available and nearby would be very wise. Make sure you have epinephrine, some Benadryl, and albuterol, and then bring your vital tree in so you can be checking their vitals on a regular basis as well.
Yep.
I think that is it. Did you have anything to add there, Jen?
Yeah, so it was mentioned by someone that not all facilities may have what we call as an e-kit, even though we're really familiar with that term. So that really, for everybody who doesn't have e-kits, is just your on hand and your readily available medications. The epi is what we would use for any kind of anaphylaxis. Diphenhydramine and albuterol are really just supportive care for symptomatic relief. So just to make sure that that's understood with that e-kit, that the epi is really the important part of that. And it can be redosed every 5 to 15 minutes until your EMS arrives.
And Leslie just pointed out that this can be the same e-kit for when we do our flu and booster rounds. And the one other thing that I do want to mention, the EUAs are great. If you actually pull them up and read them, they've got all the charts with the reconstitution and the flow rates and all that stuff. They could be a little bit confusing, but even I figured them out. So I think, they're worth taking the time to look at if you guys, if you have a new COVID case in your facility and you want to really be prepared, read those over because they're worth the read. So, back to you, Singh.
Thank you. So much great information here. Well, we'll move into our question and answering session, and I invite all the panelists to answer our questions. And the first question I was going to ask to Clay Watson, but he preempted me by putting a question in the chat box. And and so he was, I think his joke, you know, if these medications have no preservatives, are they organic? We'll let you think about that one. but Clay, one of the questions people asked ahead of time was, you know, what dose adjustments do we need to be aware of for monoclonal antibody? We can let you start in the panel also.
It's a very good question, and one we should always know about. And a great job on the presentation to everybody. The one thing I would pile on top to those EUA handouts are very informative. And the same information is packaged in a different way on the manufacturer's websites as well. So Regeneron-cov.com or Eli Lilly or GlaxoSmithKline, they all have it in a simpler to view format. So whichever monoclonal antibody you're looking at, you can get the same information from their website. In terms of dose adjustments, so there's no dosing adjustment for liver dysfunction or renal dysfunction. I think those are the two that everybody thinks of, right? So you don't have to reduce the dose if they're on dialysis or if they have cirrhosis. It's all the same dose. Just keep in mind that these are for people who are 40 kilograms or more. Hopefully none of us have patients that are less than 88 pounds, but it's possible, right? So keep that in mind. And the main dose adjustment, I saw it on one of the slides, is if you're doing post-exposure prophylaxis with the Regeneron product, and you have to do it for an extended period of time, it goes from 600 of each down to 300 of each at 4-week intervals. That's really the major dose adjustment that I'm aware of.
And then not a dose adjustment, but there's the infusion time adjustment. If the patient is in that little range that is probably not our patients, but if they're less than 50 kilograms, so greater than 40, less than 50, if they are in that range, then we have to increase that infusion time by 70 minutes.
Thank you. And just to clarify, I think too, Clay, when you said the post-exposure prophylaxis, if someone's getting the treatment for the first exposure, it's really the same dose as a treatment dose.
Same
it's
dose.
only for subsequent treatment
Exactly.
or prophylaxis
Exactly.
that you would change. And it looks like there is a question in the chat box. I wonder if we could pose this to you as well, Clay, or anyone else who would like to chime in. What is your suggestion for frequency of vitals during monitoring after receiving the treatment? And assuming that the diphenhydramine is oral, is that what that means?
Well, frequency of checks. So what we have been telling our nurse practitioners in Optum would be Q15 minutes. So you'd want to watch people, especially when you're starting it, because they're going to start to get a little bit itchy, or if they're going to have a reaction at all, which by the way is very, very rare, which was stated earlier. It'll be itchiness or chills or fevers. It'll be a systemic reaction. And so you want to watch them fairly closely, but in terms of vitals, it would be every 15 minutes would be my recommendation. I am excited to hear what other people think about that too.
I know what they've said from the federal level with HHS is they said the minimum would be before and after the infusion and before you let them go home. But from listening to other states, it seems like the every 15 minutes is the more common model.
Yeah, no, I agree as well. We discussed this together as a facility, and that's what we decided to do every 15 minutes for the first hour after we did all of our sub-Q. So giving the medication was pretty quick, but then we watched them for an hour afterwards, and that's what we decided as well.
It sounds like we have a sort of an informal consensus there. There's a question in the chat box. Perhaps maybe Diana, if you'd like to start. What is the current recommendation for when COVID-19 booster can be given after MAB treatment, for treatment or for post-exposure prophylaxis?
Yeah, so the official recommendation for that, which is based on the half-life of immunoglobulins in the body, is that you should wait 90 days after giving monoclonal antibodies before giving another COVID shot, whether it's a booster or an initial.
Yeah, I just want to thank you for saying it in that way, because you could be giving a third shot or a booster shot or the second of 2 shots for monoclonal antibodies. But it seems like that whichever one of those shots you're giving, you should wait 90 days after the monoclonal antibodies. So I have another question that we had submitted prior. And it said, what types and what are the rates of adverse reactions to monoclonal antibodies? How common is it? Does anybody from the panel want to weigh in?
I'll jump in there on the Regeneron. As I recall, it was ridiculously low. So Regeneron was tested at, remember the dose is 600 and 600. It was tested up to 8,000 milligrams. And so they did have adverse reactions, but it was 10 out of 4,206 for a 0.2%. Now that was for reactions of grade 2 or higher, meaning more severe reactions where you would stop the infusion. So maybe some throat itching or shortness of breath or generalized urticaria. So very, very, very rare in the world of monoclonal antibody treatment, at least, to be that low. So you could say probably less than 1 or 2% across the board and be pretty safe. And then if you get into the subcutaneous treatment dose, those are, the treatment injections, the reactions were a little bit higher, but they were mostly skin related reactions. So, and that was 12% versus 4% in people who received the placebo.
And I'll tag on to that. I'm familiar with that same study that Clay is referring to. So just to note that those 10 patients that did have the severe reaction, all of them resolved with 1 dose of Epi.
Thank you so much. And, I thought it was interesting that we should also educate everyone who's going to be monitoring to these patients that it's not only, a severe anaphylactic reaction, but sometimes people have nausea or vomiting and they can present differently with allergic reactions, and that we should just be aware that that can happen as well. Jen, have you seen, or Singh, have you seen any other type of reactions with this monoclonal treatment?
In my limited experience, I haven't seen any reactions.
Great, thank you. Singh, do you have the next question?
Yeah, thanks for bringing all that up. The next question I'll pose to everyone on the panel. How should we interpret exposure for purposes of post-exposure prophylaxis? Allison, would you like to start? What would you think about with your patients?
I think that's a tricky question. And I know I kind of set myself up for that one because I mentioned it in our slides. I think the one thing that the first thing I would ask is, what does our supply of the monoclonal antibodies look like? Because really, if you're in a nursing home, we know how quickly things can spread from one unit to one room to another unit very quickly. And so I guess when weighing that decision, I'd want to know what my pharmacy supply of the monoclonal antibodies look like. Certainly a roommate, or if you have rooms that have 4 to 6 residents all staying in the one room, I would treat all of them. And if it's an isolated, I would keep it to that. But whether or not you would do a whole wing, I think would, for me at least, depend on what our supply looks like.
Can I weigh in? I think this is
Yes,
such
please.
an interesting question, because it seems like every state and every provider has a little bit of a different answer. So I think there's a lot of room for maneuverability, but I do like that NIH guidelines. So it helps us kind of think through, gosh, if I have in a hallway, I have 3 unvaccinated folks and they're all on dialysis, they're going to be pretty high on my list for prophylactic monoclonal antibody treatment. And then maybe I have someone who's on cancer treatment, even though they've been vaccinated, even if they've gotten their booster, I'm going to be concerned that they really haven't mounted the appropriate response to their vaccine. And they may be high on my list too for getting prophylactic monoclonal antibody treatment. But that kind of helped me think it through, because as Allison said, it would be very hard, not only for supply wise, but even for nursing wise, to give a whole wing monoclonal or a whole floor prophylactic monoclonal antibodies. So I think that I would kind of see what the capacity was for my facility and the need were for my patients.
Very measured approach. Yeah, thank you.
I would just lean into that a little bit, right? I like all the things you're saying, right? What was their exposure and what is their risk level? Two things to think about. But then in addition to supply, what is the staffing and the appetite at the facility for doing this, right? Can they handle 10 doses? I mean, that's a lot of extra work. And we got to be on top of that before we start ordering. Or you're going to be in big trouble with the DON, not me.
Just to dovetail on that, I completely agree with you, Clay. And one of the things that I found to be pretty useful, at least in my experience, is to do some prophylactic education and to really make sure that it's on the tip of their tongue, and that we talk about the fact that this is what we've got for mild COVID-19 infections or prophylaxis. This is what we have. It's an opportunity, but so that we can have our staff and our leadership really be invested in monoclonal antibodies.
And Jen, do you have any different perspective on that?
I think just being prepared, just like everybody is saying. So, what we did to mobilize them early on and get them to the facilities, I think was key. When Sing went to go prescribe them to her patients, they were already there, as she had mentioned. And that's because we identified, for one, some of our facilities are in rural locations. So in order to transport the meds to these rural places or monoclonal antibodies could take a couple days, delivery time and packaging and getting it there. So for them to have them readily available, when you're looking at a 10-day or less window when you want to start the treatment is really key.
Diana, I don't. Oh, go ahead.
Oh, we also have another question from Steve Atkinson. Hi, Steve. I'm curious how long we can wait to give a patient Regenco after COVID-19 exposure. The package insert says 10 days, but the New England Journal of Medicine study, I believe, only allowed up to 4 days after exposure. What are the thoughts of the panel? Panel, what are your thoughts?
So the clinical trial that studied the post-exposure prophylaxis was based on a 96-hour window. However, there is no requirement or limitation in the EUA. So they recommend as soon as possible, but they haven't said after X number of hours or days, you're not eligible anymore.
Thank you so much.
Obviously, if they don't develop disease within that 14-day window, they're probably clear, as long as they don't have additional or ongoing exposure. So that would probably be your outer limit.
Yes, agree.
Do we want to, there was a question also in the chat box from a little earlier. Do we need to adjust the infusion rate for patients with CHF? Jen, do you want to weigh in on that one?
Yeah, sure. There's no adjustment for CHF. Just the increased infusion time based on weight is the only adjustment.
I guess anecdotally, I will say 310 milliliters per hour is pretty quick, right? A fellow physician's mom got mAbs, and in an outpatient setting, she, really felt like some, I don't know that it was flushing of her head, but she really sort of felt it. So yeah, you might just be mindful anecdotally.
I mean, I guess my question is, because I was the one who posted that question, is, when I give, fluid boluses to my CHF patients, I do run it slower. Is there any harm in running it slower if we are worried about overflowing them too quickly? Do we have guidance on that at all, I guess?
It's extended monitoring, right? So if you run it slower, you're just extending the time that you're monitoring them. And realize, right, our patients either have AFib or they're about to have AFib, at least a large percentage. And so tachycardia and arrhythmias are some of the side effects you can see with an infusion reaction. So no harm in slowing it down, but you just got to extend that that monitoring window.
Oh, another question that had come through has to do with interpreting who is high risk. In your judgment, maybe you start with Hillary. Would someone who is a smoker be considered high risk for COVID-19 and could be qualified for this treatment, even if they had no other risk factors that aren't listed on that EUA?
In fact, I think history of smoking is actually listed on the EUA. I really appreciate that the EUA is so detailed and clearly says that a healthcare provider can use their clinical judgment and shared decision-making and does not have to list any of the actual, sort of the example chronic medical conditions that they give. Risk, I think, is in sort of not the long-term care facility, perhaps a little bit harder to identify currently because we have evolving variants in it. And for people who are borderline, especially when it can be difficult in the community to access mAbs, it's a more complicated question. I think in the long-term care setting, it's more straightforward to identify who's at high risk.
So we are at the top of the hour. It is 5 p.m. Certainly appreciate all of your great questions and the panelists and presenters for fielding them and presenting your information. All of these slides will be available through CMDA. We'll have the recording up on our website. And we do plan to have our monthly meeting on the first Tuesday of October as usual. So that'll be October 5th. If there are any lingering questions, feel free, or you can either put them in the chat box real quick or email us. We'll try to get our experts to weigh in on them. But thank you all so much for joining us.
Thank you.
Thank you, everyone.